My name is Jack Elias. I'm the Dean of Medicine and Biology and Senior Vice President for Health Affairs at Brown. Along with my colleague, Dr. Ashish Jha, who's the Dean of the Brown University School of Public Health, I would like to welcome you to the Paul Levinger Decoding Disparities Seminar Series and to the series Endowed Lectureship, which is given today by Dr. David Williams from Harvard. This series is part of a joint effort between the Warren Alpert Medical School and the School of Public Health to focus on the inequities and health disparities that are experienced in healthcare today. Although health disparities are certainly not a new issue, we are now in a current moment in history where an unprecedented public health crisis and mass movements have collided to shed light on centuries of systemic racism in the United States, including the healthcare industry. As academic healthcare leaders, we believe we have a responsibility to build community awareness and create a safe place for current and future healthcare professionals to discuss how disparities in race, ethnicity, and culture and economic inequalities impact their chosen fields. This lecture is part of that effort. It is my hope that after this lecture, you will have a better understanding of what we need to make progress on and what still needs to be done as we work toward resolving these issues. Before I go any further, I would like to thank Sharon Rounds, Associate Dean for Clinical Affairs at the Med School, and David Williams from the Brown Center for Health Equity Research in the School of Public Health. They assembled a wonderful team that worked tirelessly to bring together a superb lineup of scientific leaders on this topic. I'd also like to shout out to the members of those teams who continue to work to make this a wonderful event. As was mentioned, we are lucky enough to have the lecture series sponsored by the Paul Levinger Professorship Pro Tem in the Economics of Healthcare. The Paul Levinger Professorship was funded through an endowment established in 1987 to honor the memory of Paul Levinger. The gift was made by his wife, the late Ruth Levinger, and his daughter, Bette Levinger Cohen, and her husband, Dr. Jonathan Cohen, who was a pediatrician from the Brown class of 1959. We are pleased that Bette and John have been regular attendees at other Levinger lectures over the years and have been joining us again throughout this series. It is support like that we have obtained from the Cohens that allows us to continue to do this important work. As regards Mr. Levinger, he was the president and treasurer of the Spidell Corporation. He was a member of the corporate board of the Rhode Island Hospital, the Beth Israel Hospital, and a former president of the Miriam Hospital. In 1969, he received an honorary degree from Brown University. Interestingly, Mr. Levinger's Spidell wristwatch building, located at 70 Ship Street, is now Brown's Laboratories for Molecular Medicine. So you can now see what was an old strength of Providence morphing into a new strength for Brown University in Providence, biotech and healthcare discovery. We are most grateful to be able to honor Mr. Levinger's legacy in a meaningful way by hearing from leaders in the field. I would like to thank Dr. David Williams for taking his immensely busy time to speak to us today. David is going to speak, and then during the presentation, put your questions in the chat function, and then Dr. Rounds will handle them after that. I would like to now invite Diana Grigsby Toussaint, who's Associate Professor of Behavioral and Social Sciences and Associate Professor of Epidemiology in the Center for Healthcare Promotion and Equity, to introduce today's speaker, Dr. David Williams. Thank you and enjoy the lecture.
Good afternoon, everyone. I am absolutely delighted to be able to introduce Dr. David R. Williams as our premier speaker today. Dr. Williams is the Florence and Laura Norman Professor of Public Health and Chair in the Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. He is also a professor of African and African American Studies and Sociology at the Harvard School of Public Health. I had the great fortune of meeting Professor Williams over 10 years ago as part of a program through the Robert Wood Johnson Foundation New Connections program, which supports junior faculty of color. And his talk was actually scheduled for right after lunch. And if you've ever been to the Robert Wood Johnson facility in Princeton, you know that their food, their spreads are absolutely amazing. But people were leaving lunch early, we were tripping over each other just to try to get a good seat to hear Dr. Williams speak. And with good reason. Dr. Williams is an internationally recognized authority on social influences on health. One of the reasons we're also so excited is that his work focuses on a very challenging issue, the issue of discrimination, the issue of race, the issue of socioeconomic status, and how they influence health. So Dr. Williams has written over 500 papers. And these are not papers that are, these are very pithy papers. These are papers that empirically look at connections of issues, look at connections of the social environment and how they actually get under the skin. To show you the depth and breadth of Dr. Williams's work, he is one of the few people who is a member not only of the National Academy of Medicine, but also the National Academy of Sciences. So this clearly speaks to the breadth and depth of his work. Dr. Williams has been involved in the development of health policy at the national level in the US, and he has served on the National Committee on Vital and Health Statistics and on 10 committees for the National Academy of Medicine, including the pivotal committee that wrote the Unequal Treatment Report. He also served as the Senior Scientific Advisor for Unnatural Causes, Is Inequality Making Us Sick?, a key award-winning PBS series that has been featured in many classes in schools of medicine, schools of public health, and as well as in sociology programs. His work has been featured in the nation's top print publications, New York Times, Newsweek, USA Today, as well as news organizations such as ABC and NBC and PBS. On a personal note, I was so excited to be able to encourage Dr. Williams, and so excited that he agreed to join us here and had an opportunity to speak to some of his previous mentees and his peers. And across the board, he is just truly revered by his peers. He is truly, he's so highly respected, truly revered by all of his previous mentees. In fact, one of his mentees, Adolfo Cuevas from Tufts University, told me that I'm so fortunate that Dr. Williams uses this balance between offering guidance and giving you plenty of room to grow as a scholar. His brain is encyclopedic. He can remember, I can tell him a simple idea and he can remember papers from 1992 and know exactly where to go or from so many years further back. On a personal note, I recently had to develop a new course on race and health. And Dr. Williams took the busy time out of his day. When he actually wrote me back, he said, "I'm sorry for the delay." And I thought, well, I'm just so happy you wrote me back. And he took the time to really help me to think about how to frame this course. And so I'm just really, really excited that he's here today. And so with gratitude and excitement, Professor David Williams.
It's truly an honor and privilege to be here with you today and to participate in this special series that you are having here at Brown University. What I want to do today is to talk about the problems of social inequalities in health, racial and socioeconomic, but then spend some time thinking about the solutions and what are the challenges and opportunities that we have to address these challenges. I want to begin with COVID-19. That's where we are right now. That's what we are thinking about, the challenge of COVID-19. And here is the latest data I have on deaths through November 10th of COVID-19 in the United States. And you can see the elevated risk for Blacks or African Americans. I'll use those terms interchangeably in my talk, as well as for Latinos in the United States. And Latino Hispanic I'll use interchangeably as well. One way to think of these racial ethnic differences in health is to think of If all groups had died at the same rate as white Americans, then 21,200 Black Americans who died from COVID-19 would still be alive, and 10,000 Latino Americans would still be alive, and 1,000 Native Americans would still be alive. So that's one way of making it concrete what these racial differences in COVID-19 mortality have really meant. I think it's really important to recognize that what we see in the United States of racial ethnic inequities in health is a global phenomenon. And I have data from around the world. I don't have time to show you all of it, but I want to give you some examples. Here is data from the United Kingdom, data deaths, COVID-19 deaths, relative to whites in England and Wales. For males, you could see that Black males have, these are odds ratios, 4.2 times more likely to die than their white counterparts. So the racial gap in England and Wales is larger than the racial gap in the United States. We can come back to that in terms of, and everyone has access to the National Health Service. You can see Bangladeshi, Pakistani 3.6 times, Indian males 2.4 times. And if we look at the data for females, it's very similar, 4.3 times, Black females compared to white females in England and Wales, 3.4 times for Bangladeshi, Pakistani, 2.7 times for Indians. And we have what we see with COVID-19, we see for a broad range of outcomes. So here is infant mortality in the United States 2015, elevated mortality, babies dying before their first birthday for Blacks and for Native Americans. If you look at England and Wales, 2014, elevated infant mortality for Blacks from Africa, Blacks from the Caribbean, Pakistanis, markedly elevated rates. And if we look at data for South Africa, and these are now odds ratios, and these are statistically adjusted for a broad range of factors. So the bivariate relationship is actually much larger. And you can see infant mortality in South Africa mirroring the pattern of apartheid in terms of the ranking of racial groups in that society, with Blacks having the highest rate, then comes coloreds, then comes Indians, then comes whites. If we look in Latin America and look at the Afro-descended, the African-descended population in Latin America, in Costa Rica, in Panama, in Uruguay, in Venezuela, in Brazil, in Ecuador, in Colombia, African-descended populations in Latin America have higher infant mortality than the non-Afro-descended populations. If we look at the indigenous populations in South America with infant mortality, in Costa Rica, sorry, I hit that too quickly, in Uruguay, in Mexico, in Colombia, in Brazil, in Venezuela, in Peru, in Ecuador, in Panama, Guatemala, Bolivia, we see the indigenous population having elevated risk. So my point is, this is a global pattern that we see. I have data for Australia and New Zealand that I haven't showed you, but it's a global pattern that we see. How do we make sense of these racial inequities in health? Well, there are large inequities in health by socioeconomic status in the United States and elsewhere. And in fact, the socioeconomic gaps in health in the United States are often larger than the racial ethnic ones. Although we tend to focus on race and not on socioeconomic status, I'm going to make the case today we need to look at both of them together, and I will show you that in a minute. But here is data from one study I was involved with some years ago, using national data for the panel study of income dynamics, looking at all-cause mortality by household income, and these are relative risk, and you can see low-income Americans have a overall mortality rate that is 3 times larger than that of high-income Americans, but it's a graded relationship. Every higher level of household income was associated with a lower risk of mortality. That gives us an important clue, because there are large racial inequities in socioeconomic status. When I say socioeconomic status, I'm referring to income, education, occupational status as the common indicators of socioeconomic status. So here's data from 2018 on racial differences in income in the United States. And I just want to present these national data from the US Census Bureau in a way that you can't miss the point. So I'm standardizing on the household income of white households as $1. And then for every dollar of household income, Asian households receive $1.23. Almost 70% of Asians are immigrants. They have the markedly highest level of education in the United States. And Asian households have more persons contributing to household income than any other group. So a per capita measure of income would have given whites the highest rate, but a household measure gives Asians the highest rate. But let's look at the historically disadvantaged groups. For every dollar of household income, remember this is 2018 national data, white households receive, Latino households receive 73 cents, and African American and Native American households receive 59 cents. What is striking about the 59 cents figure for Blacks is that it's identical to the Black-white gap in income in 1978. You heard me correctly, I did not misspeak. I said the racial gap in income in 2018 for Blacks compared to whites is identical to the gap in 1978. Why did I pick 1978? 1978 was the peak year of the narrowing of the Black-white gap as a result of the civil rights policies of the 60s and 70s and the anti-poverty policies, the war on poverty of the 60s and 70s. And the gap was reduced to 59 cents. And in 2018, it is still 59 cents. Most of my students think we have made a lot more progress than that. Has it been stable over time? No, it hasn't. From 59 cents in 1978, it declined throughout the decade of the 1980s. Reaganomics was not good to the Black community. And it wasn't until 1994 that it got back up to 59 cents, and it's been a penny up and down since then. Now, as bad as these data look, these racial gaps in income, they markedly understate the racial gap in economic status. What do I mean by that? Well, income captures the flow of resources into the household. Income tells us nothing about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth, home equity, other property, check and savings, equity in vehicles and businesses. So when we look at the economic reserves that households have, and here is the latest data from the Federal Reserve Board on race and wealth in the United States. And again, I'm putting it in a way you can't miss the point. For every dollar of wealth that white households have, Black households have 10 pennies, and Latino households have 12 pennies. What this low economic status means is that although we are all in the same storm of this COVID-19 pandemic, when you are low in economic status, you are in a different boat. You're in a boat that is not as equipped to weather the storm. And so low income and low economic status in the context of COVID-19 has made it very challenging for many persons of low income to work from home. That's a luxury they don't have. With overcrowded housing, social distancing is a challenge. Low-income and minority workers are overrepresented among many of our essential workers, our drivers, our building maintenance staff, grocery store employees, and transportation employees. And people who are struggling financially often struggle in many ways to live a healthy life. And then there is the added burden of race. What do I mean by that? Well, when my career started a while back, most researchers thought that racial differences in health were simply a function of racial differences in income and education. And if we looked, for example, at Blacks and whites at the same level of income and education, race wouldn't matter. We now know that life is more complicated than that. I'm going to show you here national data for the United States. Life expectancy at age 25, overall for Blacks and whites, and then by level of education. Overall, the average white person at age 25 will live 5 years longer than the average African American. If we look within the white population, whites with a college degree or more education will live 6.4 years longer than whites who have not finished high school. And within the African American population, those with the highest education will live 5.3 years longer. So you see, both for Blacks and whites, the gap within each group by education, it's also true by income. I'm only going to show you the education data in the interest of time. The gap within each group is bigger than the overall gap. However, It's not either or. We need to look at income or education or any indicator of socioeconomic status along with race at the same time. Because what we find is that every level of education, race still matters. So white high school dropouts still live 3.1 years longer than Black high school dropouts. And as education increases, the gap widens. And remember, this is national data for the United States. And arguably one of the most stunning statistics I will show you today is this. The best of African Americans, those with the highest life expectancy, college degree or more education, have lower life expectancy than whites with a college degree, than whites with some college education, than whites who have finished high school. So what do these data tell us? There is something profound about your income and education that matters for your health, regardless of your race. But there's something else about race that matters, even after you've taken income and education into account. And researchers have been asking for the last 25 years, I think very seriously and empirically, could racism be a critical missing piece of the puzzle to understand the patterning of racial disparities in health? So I want to tell you a little bit about the house that racism built. I see racism as part of a societal system. It's linked and it's shaped by and is reshaped by powerful political, legal, economic, religious, cultural forces and historical events. It is primarily a system. This system is premised on an ideology of inferiority, and it differentially allocates opportunities and resources. This can lead to, at the individual level, to negative attitudes and beliefs, prejudice and stereotypes. It can lead to differential treatment by individuals and social institutions, but racism is not primarily at the individual level. It's really systemic. It's really what happens at a system level. So I want to talk to you about, at a system level, we talk about institutional, structural, systemic discrimination. And I want to give you an example of one, and it's important to distinguish that individual, structural, systemic from the individual level. And the one I will give you of, unrelated to the topic, but we've all been thinking a lot about presidential elections of late. So I want to give you an example of institutional discrimination linked to waiting to vote in the presidential election. This is national data for the United States. In the 2012 presidential election, on average, African Americans waited 23 minutes in line to vote, whites waited 12 minutes. Importantly, none of this reflected the behavior of local precinct workers that treated African Americans badly, sent them to the back of the line, had them wait longer. No, what it reflected was the budgeting and space allocations, the local administrative procedures that led to how many voters were being served by a polling site, how many precincts in an area, what was the level of staffing. So what I'm saying is, it was all about policies and procedures, known bad behavior by individuals, but the outcome is quite unequal. Well, let's talk about an institutional mechanism of racism that we don't often talk about that contributes powerfully to racial inequities in the United States, and that is residential segregation. John Sellers, a historian at Duke University, wrote a book about the origins of segregation in the US South and South Africa. He argued that residential segregation by race in the United States was one of the single most successful domestic policies of the 20th century in the United States. Well, why would segregation have dramatic effects? Think of segregation as a toxic emission produced by an industrial plant. It is often imperceptible because none of the politicians talked about it in the last election, but it causes illness and death, and valuable resources disappear when segregation shows up. Resources like quality schools and safe playgrounds and good jobs and healthy air and water and safe housing and good transportation and even access to good medical care are all linked to where you live in these United States. Let me give you some empirical data. These are two of my colleagues at Harvard, two eminent sociologists, William Julius Wilson and Robert Sampson. They conducted a national study of the 171 largest cities in the United States and said there's not even one city where whites live under equal conditions to Blacks, and that the worst urban context in which whites reside is considerably better than the average context of Black communities. And someone says that is 1995 publication, Have Things Gotten Better? So here is a 2020 publication. Dr. Dolores Acevedo Garcia from Brandeis University has created a neighborhood opportunity index for every county in the United States, which she's used 27 different indicators of access to opportunity for children, that like the quality of schools and the high school graduation rate and the employment rate and home ownership rates and income levels and the quality of the environment, air, water, soil pollution, and access to resources for health like green space and healthy food outlets. And using this indicator, she ranked the 100 largest metropolitan area and showed the percentage of children at different neighborhood opportunity levels in the 100 largest metro areas in the United States. And what she shows, that in very low and low opportunity areas, 2/3 of all Black children and 58% of all Latinos and 53% of all Native Americans are in very low or low opportunity areas, compared to about 1 in 5 whites and Asians. On the flip side, who is present in the high and very high opportunity areas? Almost 2/3 of white and Asian children, compared to about 1 in 5 African American and Latino kids. So segregation leads, even in 2020, to unequal access to opportunity. Think of segregation as an electronic fence that creates an invisible cage that prevents children from stigmatized background having access to the social, economic, psychological, educational resources that foster development and well-being. In fact, we don't even recognize there is good empirical evidence, and I'll show you 2 studies today, that segregation is the central driver of the large racial differences in income and education that we started off with in the first place. This is David Cutler, an economist, respected economist at Harvard University. He did a national study of young African-American and whites making it in the labor force. He showed statistically, using very rigorous econometric methods, that if you could eliminate segregation in the United States, you would completely erase Black-white differences in income, in education, and in unemployment, and you would reduce Black-white differences in single motherhood by 2/3. All of those differences are driven by opportunity linked to place. And here is another Harvard economist, Raj Chetty, who has done an amazing study. He has looked at the entire US population, looking at all census tracts from 1989 to 2015, and he's done an intergenerational analysis. Let's look at Blacks and whites who start out at the same household level, income level, and let's see how their children are doing. And he finds, for example, that Black boys have lower earnings than white boys in 99% of census tracts in America, controlling for parental income. Why? They live in neighborhoods that differ in access to opportunity. Why? The power of residential segregation continues. Black boys do as well as white boys if they live in neighborhoods with good resources. The problem is there are essentially very few of such neighborhoods in these United States. So when we talk about the inequities in economic status that we see, that they matter for life and health, there is a temptation to talk about they reflect a broken system. I would argue that they do not reflect a broken system. In fact, they reflect a carefully crafted system functioning as planned, successfully implementing social policies, many of which are rooted in racism. They are not accidents, they're not acts of God. It illustrates how racism, and through its structural institutional mechanisms, has produced a truly rigged system in the United States. So we talked about racism, and one mechanism, segregation is not the only one, it's the only one we have time to talk about today. But then let's talk about individual discrimination as well. This is Diva Pager. She did one of these classic audit studies in employment, took 2 Black men, 2 white men, dressed them similarly, give them identical resumes, and had them apply for 350 entry-level jobs in Milwaukee, Wisconsin. The only thing that was different was the race of the person handed in the resume. Everything else was the same. She threw a wrinkle into this audit study, had one of the African Americans, one of the whites said he had served an 18-month prison sentence for cocaine possession, so he had a criminal record. She found what we would expect to find. If you said yes, you had a criminal record, and whether you were white or you were Black, you were less likely to get a call back for a job. But she found something we didn't expect to find, and it was this. It was easier for a white male with a felony conviction to get a call back for a job than a Black male whose record was clean. Their resumes were identical. There was a meta-analysis published last year that looked at, in the last 25 years, has there been a reduction in discrimination in employment in these audit studies for African Americans? And the answer is there's been no reduction. To make you feel a little better, there was a similar study published last year in the United Kingdom that went back 50 years. And the level of discrimination in audit studies like this in the UK is unchanged from 50 years ago. This discrimination at individual level is not only in employment. There are high quality scientific studies that document discrimination persists in many broad areas of society, from hailing a taxi, to buying a home, to being pulled over by the police, to renting an apartment, to the cost of bail, to getting insurance, in obtaining bank loans. Discrimination is in fact pervasive, and the scientific evidence is overwhelming. But discrimination are not just those big things that happen. And in some of those cases, you don't know whether you were discriminated against if you didn't get a job. You don't get everything you apply for. But at least some of the experiences of discrimination people are aware of. And Martin Luther King said back in 1967 that discrimination is a hellhound that gnaws at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as a truth in the society dominating them. That suggests that the subjective experience of discrimination, which is just a fraction of the total discrimination, could be a source of stress for individuals who experience it. I have developed a number of measures to capture the subjective self-reported measures of discrimination. I want to tell you just briefly about the Everyday Discrimination Scale. It's one of the measures I've developed. It's the most widely used measure globally right now to study discrimination. It doesn't capture all experiences of discrimination, just the little day-to-day indignities. Being treated with less courtesy and respect than others, receiving poorer service than others at restaurants or stores, people acting as if they think you are not smart, or they're afraid of you, or they think you are dishonest, or they're better than you are. I just want to show you, this slide just summarizes from a recent review some of the studies, the relationships that have been documented in research studies between everyday discrimination and health outcomes. So higher levels of everyday discrimination is associated with incident metabolic syndrome, incident cardiovascular disease, incident breast cancer, incident type 2 diabetes, to a number of high-risk behaviors, to a number of markers of subclinical heart disease, heart rate variation, AFib, coronary artery calcification, to blood pressure, to poorer sleep quality and duration, to higher levels of a broad range of biomarkers, from inflammation to cortisol, to telomere length, to obesity, reductions in screening for disease, as well as mental disorders. So this gives you just a sense of this is summarized in more than 200 peer-reviewed published papers looking at everyday discrimination linked to a range of health outcomes. And the challenge with discrimination for populations of color in the United States is discrimination is only one source of stress. In my research and research of others, African Americans, Latinos, Native Americans have higher levels of economic stress, more likely to experience unemployment, more likely to have trouble making ends meet at the end of the month, higher levels of psychosocial stress, the death of a loved ones, higher levels of discrimination we've just talked about, and a broad range of higher levels of physical chemical stresses. And all of these stresses together have a cumulative negative impact. Just to make the point for COVID-19, some of my colleagues have shown that for persons, populations of color and poor people in general in the United States are at higher risk of air pollution. And if you're a higher risk of air pollution, you get a more severe case of COVID-19, and you're more likely to die of it, showing that even the physical chemical stressors also adds to the risk of death. What are the consequences of exposure to all of these stressors that I just talked about? Researchers are using the terms accelerated aging, premature aging, biological weathering to describe a phenomenon that was first documented by Arlene Geronimus, but has been shown by many researchers, and that it is this. In these United States, populations of color not only have earlier onset of chronic disease, but they are literally aging biologically, physiologically more rapidly than whites. So that in national data, for example, if you look at a profile of risk and biological dysregulation, where whites are at age 60, African Americans are at age 50. There's about a 10-year difference, and some studies of telomere length have shown the same pattern. And so it's very consistent with what we find in data from the CDC, that if we look at the earlier onset of disease for blood pressure at age 50 to 64, 61% of African Americans have hypertension compared to 41% of whites. And you see a similar pattern if you look at diabetes, you see a similar pattern if we look at stroke. I could go down the list, but you get the point. So I'll move on. And this matters profoundly for deaths from COVID-19. Here is a study from New York City of 12 hospitals in New York City, almost 6,000 patients. And what it shows was the comorbidities that the patients had, of the people who were hospitalized. 57% had hypertension, 42% were obese, 34% had diabetes. You get the picture. In fact, only 6% of hospitalized patients for COVID-19 had none of the comorbidities, and only 6% had one. So 88% had more than one of these comorbidities. So we're talking about a house that racism built. We've talked about institutional racism. We've talked about individual discrimination and its triggering effects with institutional racism of a broad range of other stressors. I want to talk briefly about cultural racism, that the racism that's embedded in the stereotypes and the assumptions of our culture and our social institutions. And these negative stereotypes can trigger racial discrimination. And you said, what are those stereotypes and where do they come from? A group of researchers put together a database of American culture, a database of 10 million words that captures the average reading in a lifetime of the books, newspapers, magazine articles that the average college-educated American would read. What's brilliant about this is if you've put American culture into a database, you can say to American culture, when the word Black appears in American culture, what adjective most frequently co-occurs with Black? It's poor, then violent, then religious, then lazy, then cheerful, then dangerous. When white occurs, wealthy, progressive, conventional, stubborn, successful, educated. For the fun of it, when female occurs, distant, warm, gentle, passive. When male occurs, dominant, leader, logical, strong. These are the associations you have seen if you were raised in this society. Here are the 10 most common stereotypes of Blacks and whites. By the way, the number next to them is a measure of associative strength. It's not really a simple correlation coefficient, but you could think of it like that. It's a measure of the larger the number, the closer it is to one, the more closely tied those two things are in this database of American culture. But look at the 10 most common stereotypes, and you can see negative stereotypes for Blacks and for whites, but you can see the stronger associative strength and a greater preponderance of negative stereotypes. Folks, this has important implications for what we're struggling with as a society right now. It says to me that when a police officer sees a young Black male and overreacts and believes him to be more violent and dangerous than the circumstances actually indicate, we are not necessarily dealing with a bad cop. We may be simply looking at a normal American who is acting on what is deeply embedded in his subconscious based on being raised in this society. And these stereotypes matter for care. The Unequal Treatment Report was mentioned in my introduction, a 2003 report from the National Academy of Medicine that documented across virtually every therapeutic intervention, from the most simple to the most complicated, Blacks and other minorities receive poorer quality care and less intensive care than whites. I'll give you one example. Dr. Todd was an emergency room physician at UCLA. He asked a simple question. When a patient comes into the UCLA emergency department with a broken bone in the arm or legs, does your race or ethnicity determine whether you get pain medication or not? And he found that 55% of Latino patients treated in the prior year at UCLA had received, with a long bone fracture, had received no pain medication compared to 26% of non-Hispanic whites. That leaves us with this paradox. How is it possible that in a country with arguably the best trained workforce, where healthcare providers wake up every morning intending to do their best for all of their patients, can nonetheless create a pattern of care that appears to be discriminatory? And I just want to remind, in the interest of time, I've just showed you one study. Don't focus on pain. There were more studies in the area of the treatment of cardiovascular disease and every other outcomes. And this was found in every area of medicine. So whatever explanation you would come up with has to be generalizable to all of these contexts. This is not the only factor, but it's one important one. It's what we call unconscious or unthinking discrimination or implicit bias. Stereotype link bias is well documented, well studied by social psychologists for decades. It's an automatic process, it's an unconscious process. It's not about white people, it's not about healthcare providers, it's not about Americans. I like to tell my students I think of myself as a prejudiced person. And I tell them I think of myself as a prejudiced person because I like to think of myself as a normal human being. And I say, if you are a normal human being, you're probably prejudiced. Why would I say that? Well, every culture, every society, every community has in-groups and out-groups. Groups that are viewed positively and groups that are viewed negatively. And what the research says that when we meet someone who fits a stereotype based on what's deeply embedded in our subconscious, in 1/3 of the time it takes to blink out our eye, we size up that person and we make a judgment of them, and we will treat them differently. This is not just about race. Race is a prominent stereotype in our society, but you may not have racial, when I say you're prejudiced, you may not be racially prejudiced. But I would ask you, what are the deeply embedded stereotypes you have about fat people, about gay people, about poor people, about women, about old people? These similar processes would operate. And Lisa Cooper from Johns Hopkins shows that providers high on implicit bias, it not only affects the care they provide, but it affects the quality of the patient-provider relationship. So we've talked about mechanisms of racism and how they operate, and then they lead to inequities across a broad range of domains. And the presence of these inequities confirms for persons in society looking the stereotypes that give rise to some of them in the first place. And the stereotypes go back to reinforce the system of racism that existed to begin with. So what can we do about all of this? First of all, healthcare alone does not have all of the answers. Only 3% of our healthcare budget is spent on prevention. So healthcare is important, but we need to go beyond healthcare as well. But let me begin by talking about what we can do to build more health into healthcare. One is we can ensure access to care for all. Here is a study from the state of Delaware, where they developed a colorectal cancer screening program and provided it to everyone in the state. And 2 years later, added a colorectal cancer treatment program. And what they were able to do in the state of Delaware, when they did special outreach to the Black community with navigators and so forth, they were able, this is 2001 when the program, the year before the program started to 2009, they eliminated racial disparities in colorectal cancer screening. They eliminated racial disparities in colorectal cancer incidence, and they almost completely eliminated, but markedly reduced, the racial disparities in colorectal cancer mortality. striking differences indicating that it is possible to do prevention and early intervention that can reduce some of the disparities, and the annual savings as a result of the reduced incidence and early diagnosis of colorectal cancer was 8.5 million. And the cost of the program was $7 million. So it didn't cost the state money. It suggests there are more opportunities we have than we are utilizing to address and reduce disparities through timely medical care. What else do we need to do? We certainly need to eliminate inequities in the receipt of high quality care. The good news is that implicit bias can be reduced under certain conditions. Here is a study from the UK. High quality study, randomized, double-blind, parallel group, placebo-controlled design. A single dose of a beta blocker eliminated implicit bias in white providers for the next 2 hours. That's an important study for me because we are living in a world where some of our leaders are saying that implicit bias is fake news. If in fact we can, with a pharmacologic intervention, intervene and eliminate implicit bias, it suggests that there's a fundamental processes that are operating within the body that's driving implicit bias. At the same time, I don't think it's practical that we can, medicate the entire world's population for the rest of their lives. So the good news is there are a number of prejudice-reducing strategies that have been identified in social psychological studies, like individuation versus social categorization. I'll talk about that one. We process information, all of us do, by putting them into categories. Individuation says, when I meet someone, I will resist the temptation to focus on their race, age, and gender, and really try to understand that person as an individual. That's individuation instead of social categorization. I talk about a divine solution. Professor Patricia Devine at the University of Wisconsin has shown it is possible to put all of these strategies into a single program, motivate people, increase their awareness, increase their concerns. People can implement these multiple strategies and they are effective in reducing implicit bias. At the same time, Jonathan Kahn warns us that we shouldn't think that implicit bias is the magic bullet and as a panacea for all of the deep-seated racial problems, and we need to address some of the systemic problems more broadly. Another way to say that, the implicit bias in our society that may also reside in our subconscious has shaped our policies, have shaped the way our institutions are set up and are operating, and we need to identify them and eliminate those legacies of implicit bias in our institutions. What else can we do? Building more health into healthcare, we need to diversify the workforce to meet the needs of all patients. This is a disturbing study published 2 months ago in PNAS. It was a study of 1.8 million hospital births in Florida between 1992 and 2015. And it found that when cared for by white doctors, Black babies are 3 times more likely than white newborns to die in the hospital. The disparity is cut in half when Black babies are cared for by a Black doctor. Now, there's a lot we don't know. We don't know how generalizable this pattern is. We don't really know from this study what the drivers of it are. It is a disturbing pattern, but it reminds us that increasing the diversity of the healthcare workforce is an important strategy, and we have a long way to go. In 2014, there was a report out of the AAMC documenting that there were fewer African-American males in the first year of medical school across all medical schools in the United States than in 1978. We also need to provide care that addresses the social context. And the World Health Organization asks, what do we accomplish if we treat illness and send people back to live in the same conditions that made them sick in the first place? There are many options for doing this. I'll just give you 2 in the interest of time. One is the nurse-family partnership model, which sends nurses to make home visits prenatally and postnatally to vulnerable pregnant women. And the studies show that that program improves outcomes for the mother and the baby and literally saves society money, even though we're paying for a nurse to make home visits. Or the medical legal partnership born at the Boston Medical Center in the pediatrics unit. where healthcare providers, primary care providers can refer one of their clients or patients to a number of specialists. One of the specialists is on-site attorneys. Yes, because lawyers can solve problems in the lives of their clients, and all the asthma medication in the world, for example, will not help a child breathe symptom-free if that child goes back to live in the same conditions that made them sick in the first place. And the mother who has talked to the landlord made no progress can make some progress when a lawyer gets involved. What else can we do? How do we build community immunity for future pandemics? I believe we need to figure out ways to minimize, neutralize, and dismantle the systems of racism that create inequities in health. There are a number of strategies, and I don't have time to discuss them all, but I'll just mention them. We need to invest in early childhood. We need to reduce childhood poverty. We need to enhance income and employment opportunities. We need to improve neighborhood and housing conditions. We need to enhance economic opportunities to build strong families. And we need to reduce or raise awareness levels and build political will to address them. Let me just give you a couple quick examples of the evidence. I'm going to leave you with a paper that provides you more details, show you it's open access, so everyone can get it. But let me talk about some quick examples. Reducing childhood poverty. This is where the US ranks, according to UNICEF, on childhood poverty, 34th in the world. Importantly, look at the country of Ireland. The childhood poverty rate before taxes and transfers produced by the economy is 42%. But after the Irish indicate their policy preferences, after taxes and transfers, it's cut to 8%. In the US, the economy produces a childhood poverty rate of 24%. After we indicate our policy preferences, it's reduced 1 percentage point. So there's a lot we can do. There's a recent report from the National Academy of Sciences that shows a number of strategies we can implement to reduce childhood poverty in the United States by 50% in the next decade. Nelson Mandela reminds us, there can be no keener revelation of a society's soul than the way in which it treats its children. What else can we do? We can enhance income and employment opportunities for youth and young adults. Again, there's a lot of scientific studies that document providing additional economic well-being to households. No health intervention leads to improved health. Here is one study that raising the state minimum wage $1 above the federal level leads to fewer low birth weight babies born and fewer post-neonatal deaths for the year in the United States. What else can we do? We need to improve neighborhood and housing conditions. Many people think that's too difficult. It's not possible. We can't do it. Come with me to Atlanta. Purpose-Built Communities is an initiative that was born in Atlanta. And if we go to East Lake Meadows in 1995, it's a public housing project with a huge, very large crime rate, very large drug trade out of it, dilapidated housing, only 13% of adults employed, one of the worst performing elementary schools in the state of Georgia. Come with me to the villages of East Lake today. I visited it about 3 years ago. 90% reduction in violent crime, privately managed housing, half at market rate, half of the residents qualify for public housing. All able-bodied persons are employed. The school is elementary school, one of the best performing in the state of Georgia every year, even though over 60% of the students qualify for reduced price lunch. The purpose-built model shows it can be done. You can create a cradle to college, high quality education and program that can have a huge benefit for persons in our community. Shirley Franklin is the chair of the board, former mayor of Atlanta, of the purpose-built model. And importantly, purpose-built communities, mark that down, Google the term, they will provide free technical assistance to any community in the United States that wants to replicate their model. So what is holding us back as I come to an end today? What's the elephant in the room? I would say we have 3 communication challenges. We need to raise awareness levels of the problem of inequities. We need, secondly, to develop political will to address them. There's a lot of evidence, which I haven't reviewed all, but there's a lot of evidence. And 3, we need to build empathy. National data shows that most American adults are not aware that these inequities exist. W.E.B. Du Bois, an African-American social scientist of the late 19th and early 20th century, wrote a book in 1899 called The Philadelphia Negro, has a chapter on Negro health, shows large racial disparities in Philadelphia in 1899. And as he comes near to the end of the chapter, he pens these words: "The most difficult problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race." And Du Bois continued, "There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference." What he called the peculiar indifference, scientists today study and call it the empathy gap. There's a racial in-group empathy gap. We have more empathy for what happens. We feel the pain. We have compassion for what happens to a member of our own group than a member of the other group. And that pattern is found on every continent. Disturbingly, well, I mean, it's great that at age 5 in the United States, white children show no empathy gap. By age 7, there is a tendency. By age 10, it is pronounced. So we have a lot of work to do. The empathy gap matters because when there's an empathy gap, we don't have a commitment to solving problems. We feel no need to invest in improving conditions for a group that we view negatively. I want to end by saying I'm making a call to equity and not equality. Equality is giving everyone the same thing. That's fine if everyone starts at the same place and has access to the same resources. Equity is giving everyone that which they need in order that they can thrive. And remember what Plato said, there's nothing so unfair as the equal treatment of unequal people. I leave you with 2 quotations today. Martin Luther King said, "True compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring." The inequities we see in COVID-19 and in other things in society didn't happen by chance. We have edifices that produce them that need restructuring. And finally, I leave you with the words of Robert F. Kennedy. Each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. It is my hope that each one of us today would commit ourselves to being a ripple of hope. And together, we can sweep down the mighty walls of oppression and resistance. Thank you very much. Here is a paper for further reading, by the way, with Lisa Cooper, that is open access. You can find it. It's a resource with all the details that I didn't give you from the many studies of interventions. But thank you so much for your patient listening today.
So thank you again. My name is Sharon Rounds. I'm the Mistress of Ceremonies for questions today. I do want to say my internet connection just became a little unstable, so somebody may need to take over if it quits out on me, but we'll move on. So there's a lot of compliments and questions. One question is if you're aware of how race and socioeconomic status affect health issues that may be overlooked due to their lack of severity. And the example that's given is concussions or traumatic brain injury.
I don't have any specific knowledge of those conditions that you just mentioned. So I don't know the answer to that. I would say that the racial ethnic differences in health, they do not exist for every single condition. Researchers were surprised that if you look at the common mental disorders that in the United States, for example, African Americans have lower rates of major depression and anxiety than whites do, which is not consistent with all the stress and all the challenges they face, which reminds us that even in the context of stress, there are resilience resources, there are things that people do that enable them to survive. And by the way, the mental health data is consistent with the suicide data. For more than 100 years, African Americans have had lower rates of suicide than whites, although the rates of suicide are increasing, and very disturbingly increasing, especially among African American. Recent studies show elementary school children and other young people, we see marked increase in rates. So my point is, there are a few exceptions, and I just gave you an examples of them where there isn't a racial disparity, but in the case of physical health, the pattern exists across the board. I am particularly concerned in the COVID-19 era of the long-term negative effects of COVID-19. Many persons who had the disease, who have recovered, who are back at home, certainly have high levels of impairment from their condition, are not able to go back to their normal functioning. And I haven't seen yet any work that has looked at if there are racial or socioeconomic patterning of these, that particular profile. And that is of concern to me in the present moment as we particularly think of COVID.
A ripe opportunity for further research.
Absolutely.
Another question, has the correlation between race and mortality rate been studied in countries where Blacks are the majority population?
A very good question. I think what happens in many of those contexts is that we don't collect racial data. I mean, not every country. When I talk to colleagues in other countries, they always admire us in the United States because we collect racial data. And it's not that there aren't racial problems elsewhere, but it's not routinely connected in other countries. I'll give you one example. We've been collecting racial data since the 1700s in the United States, and do it every year, every 10 years with the United States Census. In the United Kingdom, the British census collected racial data for the first time in 1991. Prior to 1991, race had never been a question in the census. So my point is, we don't have data. This is the point I would make, is that racial disparities exist in all nations where I have seen data where there is racial data or other stigmatized populations. So for example, in India, it's caste and not race per se. But you find if there are stigmatized racial populations, I have one of my former students in South Korea, and he's studying discrimination of stigmatized groups in South Korea. There's studies of discrimination of stigmatized Japanese in Japan. There are Japanese who were raised in Brazil. Brazil has the largest Japanese population outside of Japan, and who have moved back couple generations later to Japan, and they are discriminated against and are stigmatized there, and you see the outcomes. So I would say wherever there is a stigmatized group, a socially stigmatized group, we see the pattern. But we do not have racial data for every country. In fact, in some countries like France, it's illegal to collect racial data.
Here's an interesting question from an undergraduate who's concentrating in medical anthropology at Brown. And this individual asks, how can doctors work to undo the effects of systemic racism? What are some action steps that we can take in the hospital setting or in our one-on-one interactions?
There's a lot we can do. If you looked at my slides about putting more health into healthcare, I'll give you an example of one study, but there's more. I think Saha is the author, and what he was able to show, he studied patients who had HIV and looked at there were disparities in the receipt of the appropriate treatment. There were disparities in adherence to the treatment protocol, and what he was able to show by using a questionnaire to capture the attitudes of providers. And basically, providers who respected their patients, who cared about what their patients thought, who had a good relationship with their patients, among those providers, there were no disparities. There were disparities in the other half of the providers. So the quality of the patient-provider relationship was a powerful predictor of even the adherence levels of patients to the protocol. So that's important. That's one important step. There's a lot of interest nationally right now in what are called, and there are a number of organizations supporting anchor institutions. In many communities, the healthcare system is in fact the largest employer. It's one of the economic drivers of the community. And there are a number of leaders of healthcare systems that are coming together, and they are the anchor institutions in their city, in their town, and they are coming together to pool resources and to figure out what can we do as an anchor institution in this community and they're doing everything. Dignity Health has invested in low-income housing and making housing available. The examples in Ohio of programs that are improving access to food that are being driven by hospitals. The Boston Medical Center right here in Boston, they remodeled their rooftop to have a rooftop garden that they use to help to provide not care, certainly for their food for their patients, but also for persons in the community. Loma Linda Medical Center, just outside San Bernardino. San Bernardino is a very disadvantaged community, has established a top floor of their federally qualified health clinic and to open what they call a gateway college that is providing education to entry-level jobs in the healthcare field that take less than a year. For persons in San Bernardino. And why is that important? In San Bernardino, prior to this initiative, less than 20% of all high school graduates went on to any higher education. That includes community college. So addressing unemployment as a strategy. So those are just a few examples. There's a lot being done, and there's a lot that healthcare systems can do to address some of the systemic underlying problems that exist in the community.
Have there been studies on why Asians seem to fare much better than other minorities and even better than whites in terms of healthcare equity? Sure.
We know exactly why that is the case. There have been studies, and it's a selection effect. Take Indians from India, for example. There's a lot of poverty in India, right? But the Indians who arrive in the United States, they have the highest level of education of any group. The percentage of the Indian immigrants with a college degree or more education is almost 80%. That compares to 31% of whites in the 2010 census have a college degree or more education. So you have what we call a selection effect. This is not a random sample of people from India. This is a select group, and they are selected on the basis of high levels of human capital. And remember, I told you early in the talk, around the world, higher levels of socioeconomic status predicts better health. So it's not a mystery in any way. And so if you compare, just for example, the Indian population, Indian immigrants, where their level of college completion is about 80% of Indian immigrants have a college degree or more education. If you compare that to Central American or Mexican immigrants, the percent with a college degree or more education is around 5%. So you're looking at very different populations. So it's not about the country they came from, it's what are the human capital resources that people have come to the United States with.
Have there been studies of educational approaches to prevent the development of the empathy gap among young children?
I think the interest and evidence for the empathy gap, and by the way, the empathy gap exists by race. It exists by other things too. The average American, some studies on the empathy gap show, cares more about what happens to a dog, a puppy, than what happens to an adult. A baby fares as well as a puppy, but adults, we are ranked lower than the puppy. So I'm saying that there are preferences that individuals have, many of them culturally driven, that shape what we do. So I would say there is a lot we still need to learn, and there is much that needs to be done on interventions with the empathy gap. From the meta-analysis that I showed you of looking at studies of the empathy gap across multiple contexts, they found a number of factors that predicted lower levels of the empathy gap. One was a lot of interracial socialization, interaction in early childhood, early in life. So kids who go to an elementary school that is much racially diverse, as adults, they are less likely to have the empathy gap. Another factor that predicted lower levels of the empathy gap was individuation. People who look at others through the process, and I talked about that. Individuation as a strategy that reduces implicit bias. It also seems to be predict lower levels of the empathy gap. That when you meet someone, you try to understand that person as an individual and not as a member of the social groups that you belong in. There's also some evidence of seeing others as working together on a common task for a common purpose also seems to reduce the empathy gap, even if those persons are of a different group than you are. So we have some suggestions. I would say this is an important area of research, because the lack of empathy, and I didn't elaborate on that, the lack of empathy drives public policy. Let me give you one example. A study done by researchers, national data for England, France, the Netherlands, and Germany, looking at an immigrant outgroup in each of those societies. 2 questions. How often do you feel sympathy for the group? How often you feel admiration for the group? It's a different immigrant outgroup in each society. And the absence, you could code them the lack, no positive affect. The absence of positive affect was one of the strongest prediction of people's policy preferences towards the group. Years ago, we replicated, I along with my colleague at Michigan at the time, James Jackson, the late James Jackson, we replicated that study in the United States in the Detroit metropolitan area, probability sample of whites. We found those answer to 2 questions. We asked how often you feel sympathy for Blacks, how often you feel admiration for Blacks. No positive affect, the absence of sympathy and admiration was the strongest predictor of whites' opposition to government initiatives that would help Blacks and for affirmative action in employment. When I say it was the strongest predictor, it was stronger than income, education, political party, whether you were liberal or conservative, your beliefs about the nature of inequality in society, whether you were racially prejudiced on standard measures. Just tell me how you feel about the group. That was the strongest predictor. So addressing the empathy gap is a key step in terms of building political will and getting Americans to wake up and say, this is unacceptable in our country. We can't have people treated that way. But if you don't care about those people, then it's not a big deal. So addressing the empathy gap is really important. But I would say we are in the early stages of identifying what might be the best options and the best solutions.
Fantastic. Well, thank you so much once again for a stimulating and inspiring presentation. And we greatly appreciate your sharing your knowledge with us today. And it was a really wonderful, wonderful experience. Thank you.
Thank you very much.